All right, good morning and welcome to our Psyfeld discussion of the suicide. So where are we starting?
Elaine's delirium.
Elaine. So what's going on with Elaine,
Hypoglycemic.
right?
She decided to fast.
Mhm.
Very long.
Yeah.
Yeah, it was like multiple days.
Yeah, it's been a while since I've done a clinical rotation outside of psychiatry. Is that a thing?
No, not for an ulcer. I've seen like intermittent fasting for like 2 days, which I don't agree with, but I've seen patients do it.
No, for prep?
Not for a prep.
Oh, so, okay.
Yeah, no.
Yeah. So you can see,
Was she not drinking water either? Like no electrolytes?
Well, she also insisted on like doing all these things in the middle of her fast. Like she was obviously not functioning well. She's like, I'm still gonna go see the psychic. I'm still gonna go attend these events with my friends. And I'm saying, like, why?
what do we think is the etiology of Elaine's delirium?
Hypoglycemia.
Hypoglycemia?
Or electrolyte?
Yeah, probably, my gut says hypernatremia.
Yeah, she's not, there's not any reason she wouldn't still be able to regulate her blood.
Yeah. Yeah, I'm sure at a point she might feel ketogenic or ketosis, and that's gonna make her dizzy, but not necessarily delirium or
Not like hallucinating.
hallucinating or even a change in the level of alertness. Getting back then, let's actually define delirium. So what is delirium before we actually get into some of the potential causes?
An acute change in mental status.
Probably consciousness.
Right, so we go by the 3 C's. All right, so we have the course is defining, waxing and waning, which certainly contrasts it with the slow and progressive course of the dementias. Right. I heard a change in mental status, more specifically,
Decline.
orientation. Right, often referred to as a clouding of consciousness. So you only have to have 2, right? So there are cognitive deficits. So that's the second thing, cognitive deficits. You only need 2, and one has to be a level of attention or concentration, right? The other one could come from multiple domains, and that includes perceptual disturbances, right? So that's 2, and there's one more is essentially is critical to understand this illness. And you already said it, but you have to say it explicitly now. Yeah, the cause, the final C, the third C is the cause. And unlike any other mental disorder where you have to actually investigate and rule out a medical condition, here you have to investigate and actually rule in that the reason for that, the cognitive deficits, the altered mental status, is an underlying medical condition and or the direct and physiologic effects of the substance. So in this way, delirium is not a mental illness, right? It's just a behavioral manifestation of a underlying medical illness, right? So, and that focuses on Elaine. She likely does have some electrolyte abnormalities. If I had to guess, it's probably hypernatremia due to severe dehydration. It's probably others. If you look at the actual DSM, they kind of break down delirium into different categories. And the reason why I bring this up is that the outlier category is mixed or unknown. So that's often where we are. Sometimes we don't uncover the cause. We can make the diagnosis suspecting the underlying medical cause because of the way it presents its course and what is presenting the actual signs and symptoms, those cognitive changes. On the other hand, when you do discover an underlying cause, you have to be very careful because very often there's more than one. So you just can't think you found the single one, and whether or not you investigate further has everything to do with the patient's course. Right? Are they improving upon correction of that cause? If Elaine eats, if she has IV fluid, and that those serum sodium actually comes down back to about 140 or normal, how does her mental status change? And if it doesn't, keep on searching. All right. What are the causes other than what we see in Elaine? And the answer is actually hidden in the Seinfeld episode, believe it or not. And I could actually go so far as to say I think that every single potential cause is actually uncovered in this episode. So instead of thinking through this like a medical student, let's think through this like a Seinfeld thing. What else did you say? Related to Elaine, unrelated to Elaine? Continue our conversation about the suicide.
The overdose.
Right, okay, so what happens with Martine? Good pickup. So he's comatose. So here we may or may not have evidence of delirium. Certainly what we see, the answer is no, right? I mean, there is consciousness and then there's unconsciousness. And under consciousness, if you want to think about it as having two levels, there's unitary consciousness, hopefully where everybody is right now. And then there's the altered state of consciousness. Could you give me an example other than delirium of an altered state of consciousness? Catatonia, it's sleep, right? And there I would break it down to normal and abnormal, right? Because sleep is a real easy example. Obviously, it's a example of the normal variant, and then the abnormal that includes states like catatonia, obtundation, delirium. Coma is unconsciousness. And that's all we see in this episode. Now, whether or not there's any evidence of delirium is coming out of the coma or prior to going in, we don't know. We don't know. What else did you say? Any other way, we said toxic metabolic, and he does overdose. Do we know what he overdoses on? I don't think so, right?
Yeah,
Yeah, okay.
Like with pain, maybe from delirious, like the psychic was in labor.
Okay, yeah, nice, that's a good one. What do you think of George in this episode with her?
This is really showed his anxiety again, because he like the studies that anything happening to his around his head. It's something like kind of happens, right? But it could end up being really anxiety and not to be. I don't know if I see what's the reason not to do things. but-
Yeah, I want to go in that direction here. Let's say this becomes a recurrent pattern of behavior, and the pattern results in clinically significant distress or functional impairment in George to a point where he comes and sees you for an office appointment. And upon your psychiatric evaluation, you uncover this pervasive pattern across 9 seasons of the situational comedy. What are some of the things you might want to consider here?
Like, consciously around him.
Let's go with the unconscious. What type of testing might you either employ or refer out here? What's a projective test? I would love to give George Costanza a workshop, yeah. Yeah. And there's another, yes, I'm sorry, the ink blot test, right, the ink blot test. You know, my gut says in being provided this ambiguous stimulus through the psychic, it isn't unlike his getting an ambiguous ink blot, and he asks, what do you see? Because he is going to project his subconscious impulses to that, and they're always negative. They're always negative. They're always self-deprecating and self-defeating.
You mentioned the brother, that case like I've never even mentioned before for the psychic, and I was like, didn't let him sing it, like, what is this person like?
Oh, it could maybe like a history of trauma somewhere.
Or
I
maybe the
think that
brother has
comes up-
failed and like cut ties for the same reason that George is stuck and has not cut ties,
Yeah.
right?
I'm not sure that comes up ever anywhere.
I don't think that's either. No,
Yeah.
no, it's a good pickup. Yeah, it's a good pickup. Yeah, I don't think you'll get this on your shelf exam, but another projective test is the thematic apperception test, or the TAT, T-A-T. And there you're given an ambiguous scene, picture, right? And you're asked what's going on in the picture. And the individual, the patient, will project their unconscious to the onto that picture and provide the answer accordingly. Again, either the TAT or the Rorschach would be a wonderful test. Yeah. Yeah. I mean, George might say, yeah, that's my little brother before, you know, what happened. Like, okay. right? So, all right, very well. So we have more on George. We have Martine. Anything else here? What'd you think of Nina? Nina or Gina?
Gina.
Gina.
Yeah.
Nina's one of Jerry's ex-girlfriends.
He had a weird
Gina.
fixation on wanting to make Martine jealous.
Yeah,
Her emotions, it seemed like there was really, it seemed like she was like, it was just like, she was like, almost like felt like she was like really acting when she was like expressing her emotions. To the point where she was trying to get Gary to kiss her during, the time, but she was being very dramatic when he didn't want to kiss her, thinking that something wrong with her, you know,
And yeah, when it came to Martine, we asked that they wanted. She was like, oh yeah, I can tell me.
Yeah. yeah. What's going on there?
people, history, but it seems like she's, like developing as kind of personality.
Cluster B tendencies.
It's just because of how flirtatious she is with Jerry, even when she is in a relationship, and how she gets really dramatic at times, almost to the point where it's like, the situation doesn't really.
One thing that the game points out at some point is like a cultural difference too, like to be aware of, because I think like some of the trauma is supposed to be like her playing on these cultural differences. I'm curious if it's like a coping mechanism to be open every happening with Martine, right? Or she like puts all her focus on something else entirely, and like sexual desires instead of like her grief and sadness. Because the second that he was back, she's got like she's back with him, and they move into a home together.
Certainly could be. And the other part of it too, which would really tease this out quite nicely, is to actually see how she's reacted to prior trauma. I mean, if this is a recurrent pattern in and of itself, or in terms of setting the pattern, just whether or not she's ever acted like this, period, prior to meeting Jerry. That would really give us a clear picture as to really where this is coming from. If we do think it's a personality disorder, and if we do think it's a cluster B personality disorder, this is not the first time it would have happened, right? So that's something to definitely investigate. Since we're just discussing the topic, what are the cluster B personalities?
Histrionic, borderline, intersection.
And narcissistic, right? If you could give me, with the exception of borderline personality disorder, if you could give me a one-liner that really defines each of the other three, can you?
Histrionic is dramatic, overly sexual.
And they're dramatic because there's a need, an emotional need to be the center of attention, right?
Right, so.
Exactly right. I think that's pretty much verbatim out of the APA. It's suspicious, but there.
Like, very sense of self. And,
Yeah, arrogant, haughty behavior, because the individual believes they're special. Yep. And again, borderline, we talked about, I think as recently as last week, a little bit trickier, but I think almost as easy to identify in a clinical vignette on your shelf exam.
Did you say that Martine, from what we've heard about him, also exhibits some cluster
I
B
think it's
traits?
fair to, I mean, I think, obviously, we're going to be consulted on this case, right? And yes, I think that's one of the things I think walking into that room, we're going to have to consider. And if the HPI or recent history suggests, we're probably going to either strengthen that differential that we've already preformed, or obviously expand it, but I think we start there. I think it's fair.
Yeah, it's like suicide attempt, ostensibly based on a perceived, like, fear of abandonment thing.
Right, like
Even his reaction to her flirting, so like,
impulsive.
Right.
it's not like,
Just like watching.
yeah, that's what I'm thinking, like, it's back and forth, but like, one of them, people love her, do everything.
The
that's
medieval
when it-
splitting.
Yeah, the splitting, that's when she's like awful, she's cheating on him, because she.
Yeah.
Mhm.
Yeah, I do think it's very fair for a clinician to walk into that. I mean, we have an open mind, we have unconditional positive regard, but we also are considering a differential, even when we just review the chart, because we have to make sure that our assessment is tailored in such a way. So as to tackle those things that we think are likely to be happening. All right, so the real reason why I had you watch this is because of Gina's behavior towards Jerry.
Mm.
can you summarize that for me? While her husband, I mean, I know generally speaking flirtatious, but when Jerry does what he does, when he reacts the way he does, I want you to focus on Gina's reaction and some of the things she says to him. So can you actually summarize that?
Goading.
Yeah.
Yeah, goading. In which way?
So rape out of his, I don't want to say comfort zone, but, like,
What kind of man are you?
yeah, like it was.
Yeah, yeah, she absolutely does that. She does just that. She attacks his manhood. Could you give me another story in which a woman character attacks the other antagonists / protagonists' manhood?
Yeah.
Yeah, I mean, it's a perfect right, yeah, and I Heart Lady Macbeth happens to be the acronym for all of the causes. Right, I Heart Lady Macbeth. Right, so including overdose and drugs. Right, so and as far as Elaine goes, her electrolyte abnormalities, I Heart Lady Macbeth is the C, so that's the comprehensive metabolic panel, the C. And as far as Martine goes, the overdose, that's the D in Lady, drugs. Right, so not only does I Heart Lady Macbeth capture the two ideologies of the altered mental states of two of the characters in this particular episode, but everyone that a medical student would have to consider when consulted on a delirious patient. And then the final, I think, teaching point to this is the actual, not only Martine's character, but the actual title of the episode itself, because how does Lady Macbeth die? Suicide by. Right. So we have this written up in a medical journal, so I'll go ahead and post that URL for you online if you want to on Twitter X, if you're interested in reading it, because it's a nice parallel between the suicide and the tragedy of Macbeth. Any questions about delirium? How do you treat it? Treat the underlying cause. All right. So you look at I Heart Lady Macbeth and you search for the underlying cause. And while you're doing that, what next? Right. So it's a biopsychosocial approach in terms of making the patient more comfortable, keeping them safe. The psychosocial interventions are what are often referred to as the delirium protocol, quote unquote. And then when that is unsuccessful, what about the biological or somatic approaches?
Like medication
Yeah.
for like agitation.
Yeah.
We did some interesting exploration with Mo and Dr. Vita, but we noticed that all the sicky patients get put prophylactically in Seroquel. And so Mo, that's like what the potential evidence what we wanted.
It just seems like there are these small studies that we've done that said, hey, if we, automatically assume they're probably going to get delirium when we treated it beforehand, that they'll recover faster and maybe end up faster. But it just seems like everything that they cite, like there's very, very small niche study of individuals without taking consideration of the age. That the individual that we had at the on, there's a 28-year-old with like no other pre. Taking these little niche things, well, it worked here, let's go ahead and do as much, but our patient that we had, it didn't seem like it was doing much.
Yeah. Yeah, right now, we just did a review of the literature, and two major meta-analyses performed showed that, unfortunately, that's not the case. And I think, just to kind of sum it up, the use of antipsychotics does not improve the severity of delirium. It doesn't improve the duration that is shortened of delirium. It doesn't decrease or shorten hospital stay. It doesn't lead to any positive outcomes when it comes to quality of life. So unfortunately, the literature in a meta-analysis simply doesn't support that practice. So I think to distill that, our clinical pearl is that we do choose antipsychotic therapy for agitation. And that's agitation that impedes essential medical care. We certainly don't use it for other PRNs like sleep. We don't do it to readjust the circadian rhythm. And we don't do it time contingent or around the clock. right? So it's as needed for agitation that impedes essential medical care or poses risk to the patient. What's your choice of antipsychotic in this case? And why? No, generally speaking, we have a starting point and then we have to basically fit it into our clinical scenario. So ultimately it is a case by case basis, but where is our starting point and why?
Things I use for agitation is Haldol, but that's typical for antipsychotic, so I wouldn't really use that for an elderly patient.
Right. So, but that's the answer. Why?
It works.
It's true, it does work.
It's highly
Most specific
potent.
for the dopamine receptor.
It's the most potent for the dopamine receptor, right? Meaning that it is most tightly bound to the D2 receptor as an antagonist. Yeah. For haloperidol, what about its side effect profile makes it a optimal candidate? So in terms of the benefit you're going to receive as a high potency, it's a high potency typical or first generation antipsychotic. So that's for the benefit. That's the intended effect. But what about its side effect profile? The side effect profile, it has little to no anticholinergic potential. And acetylcholine is a culprit in delirium, right? Acetylcholine drops, resulting in a relative excess of dopamine. And then you have that C called cognitive deficit.
That was the other interesting part of our discussion on the Seroquel, as Dr. B was saying, it's like a little bit counterintuitive to use because it has more potential to be deliriogenic.
Right. Intuitively, yes. Now, again, whether or not your patients have read the data and behave that way is another, again. So after we choose Haldol, assuming there are no other contraindications for use, if it doesn't work, we have to go to plan B. And plan B often is a second generation or atypical. And there you are losing potency and you are gaining anticholinergic side effect, right? And yet it could still work. So we do treat the patient. We don't treat the K value at the receptor level. We can't just go to a chart and say, we're going to stick with this, right? So you start with the recommendation, but you have to be flexible and be able to adapt and change the recommendation if your patient tells you it's not working, right? And that's the way patients tell us is by a one-to-one sitter needing to be in that room and all the costs incurred and or physical restraints. Of course, the other indicator will be the number of PRNs they require through the night. So when I hear no events overnight, patient resting comfortably, I'm not going to say they're lucid, awake, and alert. I'm not saying we cured anything. But one-to-one sitter not needed, and patient was without 2 or 4 point restraints this morning. I'm hearing that the regimen's working. Final questions, final thoughts. All right, thank you. Stop here. And we'll see everybody about 60 seconds with table rounds.